Okay.
Okay, well, thank you very much, everyone, for joining us in our broadcast, our first broadcast of 2023. Thank you, Dr. Poulos, for joining us this evening. And so tonight we're going to be talking about the topics we usually talk about, but we're also going to be adding another couple of topics in the health area. And we're going to get started with Dr. Poulos' update because every other month she is provided an update by King County Health Department. And so I'm going to turn it over to her to do that. Feliz Año Nuevo. Los recibimos hoy en nuestro primer programa del año. Vamos a tocar varios temas esta noche, todos acerca de la salud, unos nuevos. Y ahorita le voy a dar el micrófono a la doctora para que ella nos provee una actualización sobre cómo está la situación en el condado de Kane. Doctor?
Okay. Hi there. This is also, I believe, 2-year anniversary pretty much of when we started these programs. Mm-hmm. So the library's been kind enough to host me for 2 years now. I really appreciate it. We had a meeting of the King County Health Department Advisory Committee today, and I'm going to go over a couple slides on some updates on COVID, and then toward the end of this meeting, we're going to touch on a few other vaccines and topics about illnesses too. So, hola, gracias a la biblioteca por teniendo este programa. Y en este mes se cumplen 2 años de hacer este programa. Y le agradezco mucho a la biblioteca para darme la oportunidad de hablar con la gente en esta manera. The health department went over, we did our little COVID update. And I would like to call your attention to slide 1 that Natalie's going to show us. And the basic bottom line is that the numbers are going down, which is great. We had an early spike earlier than usual of influenza-like illness. As you know, I mentioned last time, state of Illinois tracks any illness with fever, cough, congestion, etc., that goes to emergency room. They lump them together because you don't always know what they are. And you can see from those wavy spikes how much they're going down. The pale blue line has gone down quite a bit, which is gratifying. So, because we were afraid a few months ago that the early spike might mean it's going to be a really bad winter. And at the moment, probably not, which is reassuring. So, este foto nos explica que si se ve a la línea que es un leve azul, que era muy alta, pero está bajando, que las enfermedades que incluyen fiebre y tos y resfrío y visita a la emergencia es un dato que está monitorando por el estado de Illinois. Y en este año en el año pasado estábamos preocupados en el otoño porque era muy temprano para tener tantas visitas a la emergencia, pero gracias a Dios parece que sí se subió bastante, pero se está bajando un poco más rápido también. So that's it with the first slide. If you go on to the second one, this is a little confusing. The community level is low, but transmission is high. What does that mean? Community level is defined in a complicated way. It's a couple things. It's the number of, how can I put it, people in the hospital, deaths, of which there have been very few, relatively few, serious illness, tracked in various ways, mostly hospitalizations, ICU stays. That is actually low. I can even see it at the hospital. When you look down the hall, you don't see many isolation rooms set up at all. But the transmission is substantial, and it's hard to know exact numbers because of the amount of home testing that is done. But it does seem, I can tell you from the phone calls at the office, I get multiple phone calls a day about people that have tested at home, they've tested positive, giving instructions, giving medication. For certain people, there's criteria for medication called Paxlovid. that shortens the duration and makes the illness less, is protective against more severe illness. So I know that it's still out there, but the intensity is lost. Lámina es un poco, se puede confundir, pero no se confunden. El nivel de la enfermedad se considera leve o baja, porque aunque hay muchas personas con COVID en este minuto, en general se quedan más saludables, se pueden quedar en la casa. Yo lo conozco porque me hablan por teléfono, les doy medicamento, les doy avisos, pero no se enferman hasta el punto de necesitar internarse o ponerse en el cuidado intensivo o de morir. Yo he hecho la culpa de eso a las vacunas, francamente, es la mejor cosa. Las personas que me hablen que han tenido la vacuna en general sufren menos y no tienen tantos enfermedad terrestre. So hopefully that cleared up why the site's a little confusing. Next slide, please. Okay. The majority of the cases here, and it's color coded and it's tiny, so I apologize for the vision test, but the bottom line is almost this entire bar graph as you go along is the Omicron strain. There's very little of Alpha, the original, and Delta, which was the really bad one at the kind of like the middle of 2021. There's not much of that going on. Those are like the brown color and kind of a taupe color. Most of this is different types of Omicron. The XBB.1.5 is the deep red one. That's the one that you may have seen people talking about, the Kraken strain, which is gaining strength in Europe and somewhat on the East Coast. Hasn't been a big factor here yet, but I'm sure it's going to be. But it seems to be another Omicron variant that the vaccine will work for and the Paxlovid will work for. Look at en español, explique foto es la proporción de los viruses que son tipo alfa o delta o omicron. La mayoría son omicron y se puede ver que está subiendo el porcentaje de Omicron. El color que es un rojo muy fuerte es el tipo XBB.1.5, que algunas personas lo han llamado el tipo Kraken, que es un animal de mitología nórdica, yo creo, de los qué sé yo. Pero este tipo sí es más común, está creciendo en Europa y en el parte oeste de este país, pero francamente vamos a seguir teniendo variantes y mutaciones de este virus. Lo bueno es que en este momento parece que la última vacuna, la vacuna bivalente, se cubre. So, next slide, please. So, this is a kind of a busy slide too, but the bottom line is a concern for me and for the health department is that kind of good news is that 74% of the total population has had at least one dose of the vaccine, like throughout this pandemic. Another piece of probably pretty good news is that 50% of the people over 65 have had the bivalent booster. But in between there's some numbers that are pretty low, and I'll talk about that more later at the end of my talk. Bottom line is that for a variety of reasons, people aren't being as diligent about getting the booster, that perhaps they feel like it's over, it's not a big deal, they've already been vaccinated. So we don't have the uptake of the booster the way we'd like, especially since Omicron is the prevalent form. Esos son los datos de condado de Kane de la vacunación de población. Casi 75% de la población de este condado ha tenido a lo menos una vacuna para COVID. Eso es bueno, pero el problema es que La vacuna que se había puesto hace 2 años ya no funciona. No funciona por 2 razones, porque su propio niveles de los anticuerpos está bajando y también porque el tipo de virus está cambiando. 50% de las personas avanzadas de edad han tenido la refuerza bivalente, pero debe de ser más. Y se puede ver que el porcentaje para personas más jóvenes es muy más bajo que eso. Okay. So, alrighty. So I think those are the slides that I wanted to go over. Now I'll talk more about the bivalent booster at the end of our meeting. We'll get back to COVID at the end, but now we're gonna go to some questions about COVID. Some questions about a few other topics that Martha and I have prepared. Just so you don't get bored that saw COVID all the time.
Oh yeah, COVID all the time. That's exactly right. Well, last we met in November, we were in full upswing for the triple-demic, RSV, flu, and COVID. And earlier this month, I had heard in the news channels that they were anticipating an upswing in February and March. And of course, February is not yet here, but at least for the moment right now, what we're hearing is just what you just shared with us on your slides, that we're seeing all 3 of the viruses experiencing a downward trend, which is always good news, because especially after the holidays, I always worry when the holidays, are we going to see an upswing right after? And it seemed not to have happened. And I believe it's for the same reason that you said, that people have at least one vaccine under their belts, or an infection, or for that matter. So anyway, here in Illinois, at present, while last month we were at high risk, right now we're at very minimal risk. La última vez que nos reunimos a fines de noviembre, estábamos empezando la tripledemia de RSV, la influenza y el COVID. Y iban las 3 para arriba, ¿verdad? Y bueno, como que no se realizó que se hayan habido infecciones exageradas ahora ahora que hubo las fiestas navideñas, ya pasó ese tiempo y tal parece que las cosas van bien, aunque las noticias a principios de mes estaban diciendo que anticipaban infecciones que iban a subir ahora para febrero y marzo, pues no sabemos si se vayan a realizar, porque todavía está pendiente. Lo que sí sabemos es que ahorita actualmente las 3, la RSV, la influenza y el COVID, van de bajada. Y entonces aquí en Illinois el mes pasado, como en muchos estados, estaba alto el nivel de riesgo y ahorita ya estamos en muy mínimo. Vamos a empezar with the first. Did you want to make a comment?
I want to clarify something, though. The problem is that even though the intensity is low, I still think people shouldn't let their guard down, because if you get COVID, you're guaranteed at least several days or a week, 5 days of isolation, which you should do for the public health, even if you feel good, and you quite probably won't feel great. Will you die? If you're vaccinated, it's you're unlikely to end up in the hospital or ICU or die, but it's still, I won't consider it that it's not a deal anymore. Lo que quiero clarificar es que todavía está corriendo el COVID y aunque no es tan recio en este minuto, todavía hay virus, es muy contagioso, y hay muchas personas que lo contactan, y aunque si estés una persona joven y saludable, vas a perder 5 días de trabajo, a lo menos, tal vez 10 días, y tener varios síntomas desagradables, tal vez pegar a otra gente que quieres, que son ancianos. Entonces yo creo que todavía vale la pena vacunarse y tomar varios cuidados para no contactarse.
Yeah, and that's a very good point, Doctor. That's a very good point about that you make, that the infections are still there. It's just the severity might not be what it was before. Okay, so vamos con la primera pregunta. We'll go with the first question, and that is, how does CDC track this downward trend? Or how do we know we're in a downward trend?
I think that, it's basically the same way I was looking at the Kane County. The way the Kane County does it is a microcosm of how CDC does it, with look at hospitalization rates, ER visits, but they also have more resources to, like at the state or the federal level, that they're actually looking at serology, blood tests, test results, of, nasal swabs and so forth. And not every swab is typed. Even if you get a COVID test at the hospital, they're not going to be able to tell you that it's which variant it is, but a certain subset is sent to the state lab to get typed. And that's how we know those numbers. So a lot of what happens, some of it is exactly what I showed you at the Kane County level, and some of it is at a more laboratory level with state or CDC looking at the genetic type of the viruses and so forth. What no one can have a real handle of is how many positive home tests there are. Because the only way that I know is when someone calls me and tells me. And I'm not obliged, it's not reportable. I don't have to report that to anybody.
Yeah.
La pregunta fue, ¿cómo está what's the verb? ¿Monitorando el CDC?
Monitoreando
Monitoreando el CDC en los casos de COVID. En un nivel es la misma manera que lo está haciendo el condado. Los números de personas en el hospital, en la emergencia, muriendo, en el cuidado intensivo. Pero también hacen algo que es un poco más sofisticado, que no tenemos los recursos. En este condado, el estado de Illinois o el gobierno en el CDC mira hace chequeos genéticos a las muestras del moco para ver qué tipo de virus es, si es el alfa, el omicron, lo que sea. Por ejemplo, este chart que tuvo los varios colores, no se hizo aquí en el condado de Kane, se hizo, yo creo, en el estado de Illinois.
Okay. I have several acquaintances who have been experiencing, sore throats and lingering coughs that they can't seem to shake, yet they continue to test negative for all of the three viruses. What have you observed in your practice?
Well, there's other respiratory viruses. There's the rhinoviruses, there's adenoviruses, there's many other viruses that cause upper respiratory symptoms, and they are still around as well. So that's my supposition. In the office, we test for COVID and flu. And there's people that are negative for both, but and we just surmise that it's a different virus.
Okay.
La pregunta fue, ¿qué pasa con la persona que tiene los síntomas, pero es negativo por 2 o 3 de las enfermedades del tripledemia? Y la respuesta es que hay otros virus como rinovirus, adenovirus, que provoca síntomas similares, y probablemente que es uno de esos virus. Y lo importante es saber que no damos medicamento para flu o COVID sin un test positivo.
Okay. So do you feel, doctor, that at this point in time, we've skirted probably the holiday upswing? Do you think we've skirted the February, March one as well?
Oh, geez, I don't know. That's beyond. Anything I would tell you would be more of a guess or a wish. It would be great. I would have expected a holiday upswing to have started by now, because it's almost the end of January. But I don't want to stick my neck out and say, well, we dodged the bullet. No puedo. La pregunta fue, ¿qué pasó con era anticipado que íbamos a tener un upswing, un crecimiento un alto de los números de la enfermedad después de las fiestas, y no se ha notado. Se notó después del Thanksgiving, pero no de parece que no, pero no sabemos, y vamos a ver. Todavía no. Soy feliz de ver que no tenemos tantos casos graves. Ya tenemos 3-4 semanas después de las fiestas, y vamos a ver qué pasa.
Okay.
So,
I have friends in Britain, and they're saying that they're experiencing high infection rates there. And typically, we see that we learn from what's happening in Europe because eventually it moves westward our way. Any comment on that?
I think that probably what they're talking about is what they're seeing with the 0.1, 0.5, the Kraken variant. It seems more infectious. Like I said, not necessarily more lethal, but more infectious. And we might, and that's just another reason to not be complacent about the vaccine, that it tends to travel from Europe to the East Coast to us. So maybe we'll eventually see that uptick, not so much because of the holiday, but because of a different variant showing up or increasing in amount. Do you want to repeat the question?
Yeah, la pregunta es que le digo que tengo amistades en Inglaterra y ellos están ahorita viendo altos niveles de infección. Y típicamente vemos que lo que está pasando en Europa se viene de allá para al oeste hacia Estados Unidos. Y entonces le pregunto que si tiene comentario acerca de esto.
Sí, yo creo que probablemente, porque yo lo he oído, yo tengo familia en Grecia y tienen la misma preocupación allá del tipo Kraken, que yo creo que ha hecho la culpa a este nuevo subvariante de COVID, el tipo Kraken, que parece que sea más contagiosa, no necesariamente más lethal o más fuerte, pero más contagiosa. Y hay que tener cuidado porque en general se mueve de Europa a Nueva York, para el oeste.
Okay, well, moving on to RSV, that typically affects infants and toddlers. And towards the end, we were seeing it spill over into the elderly adult age group. Did you observe this in your practice?
Actually, I can't say whether I did or not because it's not something we check for in the office. And it was rare that I had to send somebody to the emergency room and to get tested specifically for that. And since there's no specific treatment, there was almost no point. It's not like there's a Paxlovid or a Tamiflu.
Vaccine.
And so it's supportive care, for the person. So basically in our office, if they test negative, we give them all the supportive care recommendations for anybody with a upper respiratory infection or low respiratory infection.
Le pregunto a la doctora que la RSV típicamente se ve en los niños pequeñitos de meses a año, 2 años, pero que al último decían que se estaba pasando a grupo de la tercera edad. Entonces le pregunto que si ella observó esto en su consultorio.
Sí, no le puedo decir porque no tenemos este test en nuestra oficina. Y no es muy común que tenía que mandar a una persona avanzada de edad a la sala de emergencia y que le hacen ese test específicamente. Y francamente no vale la pena hacerlo si no hay un tratamiento específico. Por ejemplo, no hay Tamiflu para la influenza, Paxlovid para el COVID. Si no hay una medicina específica, es el mismo tratamiento apoyando a la persona, líquidos, descansar, medicina para tos, y todo lo usual que se hace por una infección viral.
Okay. And now this Thursday, the CDC Advisory Board will be meeting to consider the annual COVID vaccine, to consider if we should have an annual COVID vaccine, much like we do with the flu. Now, they say that only about 15% of people have received the bivalent vaccine, and which is the most recent one, the one that includes the Omicron and covers its variants. Any comment?
Yeah. In fact, I was just thinking as I looked at this question, I'll just finish up the COVID stuff now, and then we'll go on to the other 2 vaccines we're going to discuss. I think that would be great and would simplify things a lot for people to have a vaccine schedule that everyone could kind of get used to and anticipate. I think it would. I think there's a couple reasons why there's a falling off of getting boosters. A couple reasons. People are tired of the whole thing. People are a little confused as to what booster do they need and when. And um, and for example, there's a link, I think I sent Natalie a few links, the link that has to do with the COVID schedule. It's a fairly complicated thing right now to figure out where are you. I have a simplified way that I tell my patients. If you did not get a booster after Labor Day, you probably need one, because that's when the bivalent booster got to Illinois, got to Kane County. So just rather than, and why bother? People tell me things like, well, I did that already. If you got a booster a year ago, it's left your system, the immunity's gone, and you're not protected against the predominant strain. This COVID bivalent is a game changer, and there's a good reason to get it. So you can have a normal life and go to parties and hug people. Yeah? So I think if you want to put up on the screen that one link in case people want to take a screenshot, or we can put it on the site afterwards. There's a very complicated kind of CDC website for, depending on what age you are, what should you get the booster and when, and the timing and all this and that. It's way too complicated to get into here. I want to answer one frequently asked question. I just had COVID. When can I get the booster? You know, CDC website surprised me and said, you can get it as soon as you feel better. But most people, and in fact, CDC says really a lot of people just prefer to wait 3 months, and that's okay too. And it makes sense to me because you have some immunity. If you're a very vulnerable person, a cancer patient, heart failure, you may want to cut that down to 2 months. But I think there's a number of reasons that people haven't gotten the vaccine, the booster vaccine yet. And some of that is a matter of education, and some of it is a matter of fatigue. So, contestando en español, la pregunta fue, if you want to say the question
en
again.
español. Este jueves la CDC va a tener una junta asesora para considerar si es que se quieren recomendar una vacuna anual para el COVID de este punto en adelante, así como se hace en el presente con la influenza. Se dice que solamente como un 15% de las personas han recibido la del refuerzo, la vacuna bivalente, que es la que cubre ahora también el Omicron y sus subvariantes. ¿Algún comentario, doctora?
Sí, ahí tengo varios comentarios. Vamos a tener un link sobre la página de la CDC, que explique hoy día qué son las recomendaciones. Y estoy cierta que eso lo van a cambiar si tienen cambios en 2 días. Es mejor que yo les aburre diciéndoles una gran lista de recomendaciones, que lo busquen o que pregunten de su médico. Pero lo que pasa es que la gente no se entiende que la vacuna que se ha puesto, la refuerzo que se ha puesto hace 1 año no sirve ya, porque hay 2 razones. Los anticuerpos esos ya se van, no están en su cuerpo. Y el tipo Omicron es diferente. La nueva vacuna es tan buena, en mi opinión, que cubre mejor el bivalente, que casi vale la pena. Ojalá que tenía otro nombre para explicar a la gente que sí, es algo nuevo, hágaselo. Y la gente, yo creo que está enfadada o cansada de todo eso de pandemia, y también que no entiende bien que es diferente refuerza, y por eso no se ha hecho. No es que la gente que haya tenido 3 vacunas no de repente se pusieron anti-vaxxers, ¿verdad? Y tenemos como médicos de educar mejor a la gente. Es una de las razones que yo hago este programa, para explicar que sí, vale la pena ponerse la nueva vacuna, la bivalente. Y una pregunta muy común es, pues, si ha tenido COVID últimamente, tal vez es mejor esperar 3 meses, si estás una persona muy delicada, 2 meses para ponérsela. Pero si hay más preguntas, cada persona tiene que consultar con su propio médico.
Okay.
Pero eso es lo que como médicos yo creo que tenemos que explicar mejor a la gente por qué esta refuerza es importante y vale la pena.
Okay. And the links that the doctor refers to are going to be placed in the comment section of this live session. Los enlaces que está compartiendo la doctora con nosotros, los verán, los van a poner en comentarios en esta sesión de Facebook Live. Ok, pues hemos cubierto el tema de COVID y ahora quisiera pasar al tema de una nueva vacuna. So we're going to move on from COVID to discuss maybe some other vaccines that are also topics in health today. And one of them is that at least is new since I've been on the block.
Yeah, it's been around for about actually probably 15 years.
Yeah, the HPV. Yeah, so the HPV, right, is one of the more recent vaccines. And so I'm going to ask the doctor to explain to us what it is, how it's contracted, and how do we protect against it?
Well, HPV causes 95% of cervical cancer. If the current recommendation, depending upon the age of the patient when they start getting the vaccine, it's either a 2 or 3 shot series. And it'll basically, there has the potential to make cervical cancer as unusual as polio is today. It's not just cervical cancer. There's 6 cancers that are linked to HPV, and some of them affect men, like penile cancer, or both sexes, like anal cancer and cancer of the back of the throat. So it is a recommendation for boys and girls. And there is a link that we're going to put from CDC of the cancers that are involved. There is the reason to vaccinate at like the preteen age group or the young teenage group is to have the immunity on board prior to the age at which people become sexually active. And the reason to have boys as well as girls is somewhat obvious, I think. Even before we knew about the whole pharyngeal cancer and so forth, it's obvious. But now that there's really valid reasons, in addition to protecting women, that for young men to have the protection themselves against certain cancers.
Hay una vacuna nueva, ¿verdad?
Yeah, it's más o menos nueva. It's fairly new. It's about 15 years, I would say.
Okay, ya tiene una vacuna nueva que ya tiene como 15 años, que ya tiene como 15 años, pero para nosotros que ya somos mayores, pues es relativamente nueva, ¿verdad? La HPV.
Yeah.
Le pregunto a la doctora.
Para decir lo que he dicho en español también, es la vacuna de HPV. Es una vacuna más reciente que las otras que tenemos, como más reciente que la vacuna de sarampión o polio, más o menos 15 años, algo así. Y protege contra el virus, Human Papilloma Virus, es como se llama el nombre entero, que provoca cáncer, es la causa de 95% de los casos de cáncer de la matriz, del cuello de la matriz, del ano, del pene y de la orofaringal, parte de aquí, de la garganta. Y se le da a la recomendación ahorita, en este minuto, puede cambiar en el futuro, pero hay 2 vacunas o 3, depende en qué edad se empieza. Y se empieza a darse a los jóvenes que tienen, que están más o menos en la edad de middle school, para protegerlos, para tener la protección lista, para que cuando se ponen más mayores o adultos y tienen relaciones sexuales. Y si es para hombres y mujeres, porque de la lista de los cánceres que protege, que vamos a tener el link en el site nuestro, hay cánceres que afectan también a los muchachos, los hombres.
Ok, muy bien. Thank you for that. Y gracias por mencionar eso de que aplica a los jovencitos también. And thank you for mentioning that it applies to young men also. We always just think of, that it's a female vaccine, but it's not at all. These cancers,
Yeah.
estos cánceres los puede tener cualquiera, ¿verdad?
Pero el propósito, la idea que podemos erradicar cáncer de cuello matriz es muy importante porque hay dos cosas que usando esa vacuna y el test Papa Nicolau para detectar células que están propensidad a ponerse cancerosas, puede casi erradicar esta enfermedad. So I was just to say it in English, and the idea that we might really minimize to, not necessarily eradicate. You never eradicate. Very few things have been eradicated other than smallpox, but that you might minimize cervical cancer combining this vaccine and the use of the pap smear for screening to find early cancers or precancers is very exciting.
Good, very good. Well, and then moving on to another topic in health as well, only because I've seen ads for the Shingrix shot, and that one is to avoid shingles in older adults. And so I'm going to ask the doctor to explain what is shingles and who can get it and how do we protect against it, doctor?
Oh, shingles is caused by the herpes virus. It's the same virus that causes chickenpox. Anyone who's had chickenpox can get shingles. After you have chickenpox, the virus doesn't totally leave your body. It migrates into cells that are in the spinal column, and they're into like nerve cells, and goes dormant, goes to sleep. And it wakes up at a time of oftentimes physical or emotional stress, or just with age as our immune system kind of gets more frail. And that as it wakes up, it travels along the nerve and attacks the skin in the area served by that nerve. So that's why it has such an odd pattern. It's like a line or a patch of blisters on one side of the body. And before they pop out, the patient will notice a lot of pain or itchiness, and suddenly they have this weird rash just in one part of the body, and it's very painful. And it's also contagious for chickenpox. There's live chickenpox virus in that rash. And so if they have to avoid people that haven't had chickenpox, unless it's part of the body you can cover, of course. And then after it goes away, if you're not lucky, you're stuck with pain from that nerve for months sometimes. And there are treatments that can cut that short and help prevent the painfulness with an antiviral medicine plus sometimes an anti-inflammatory or steroid type medicine. But it would be so much better to just avoid getting it, because you can get shingles more than once. That's the other bad thing. People say, oh, I've had it once, I'm good. No, you're not good. You can get it again. 1 out of 3 people will get shingles. And our chickenpox is so contagious that even people that don't remember having it, I think probably a lot of them did have it, but they might have had such a mild case that it wasn't too noticeable or obvious to their parents. The great news lately is that because of I believe it was the Inflation Reduction Act, that one of the components is that Part D of Medicare will cover Shingrix, and that there will be no out-of-pocket for the recipients. Part D, you have to be careful because most doctors don't bill Part D. You have to go to your pharmacy. Your pharmacy will bill Part D. But go and ask your pharmacist about this. I think it's wonderful because it's an expensive vaccine, and it's 2 vaccines. And people don't have the money necessarily to pay $200 or $300 times 2 doses. So this is now the opportunity. I mean, Who wants to be in pain and have a disgusting rash? And it's really, if you get it near your eye, it can go in the cornea and affect your vision. It's no joke.
Ujú.
So,
Muy
um,
bien,
so
doctora.
if you want to ask in Spanish, then
Yeah.
I'll answer.
Sí, he visto recientemente muchos anuncios acerca de la vacuna del Shingrix, que es para evitar el herpes o la culebría en personas mayores. Le voy a pedir a la doctora que nos explique qué es la culebría, cómo es que se contagia uno y cómo se protege contra ella.
La culebría está provocado por el mismo virus que causa viruelas, ¿verdad? Y las viruelas, como ustedes saben, que es una enfermedad usualmente de los niños, pero puede ocurrir en los adultos. No, no lo vemos tanto como antes porque hay vacuna hoy día, pero las personas de mi edad lo recuerdan muy bien. Y después de curarse de esta infección como niño, que se nota con ampollas de todo cuerpo, mucho picazón, comezón, tos, resfrío, calentura, todo eso desagradable, el virus no va. El virus se duerme en las células de la espina dorsal, de la espina columnar, que son los nervios. Y con estrés físico, emocional o con la edad, porque con la edad nuestro sistema de anticuerpos no es tan fuerte como antes, este virus puede despertarse y viaje en el nervio, desde la columna hacia la región que está tocando este mismo nervio. Y por eso la erupción de culebría parece muy rara, es como una línea o una mancha rosada con ampollas. Al principio no se notan las ampollas, nada más se nota dolor o picazón, pero después se salen esas ampollas que sí tienen el virus y son contagiosos. Y duele y se resecan, pero después de resecarse todavía hay personas que sufren mucho porque el mismo nervio se queda inflamado por mucho tiempo. También hay un peligro que si se ocurre cerca del ojo se puede entrar en el ojo y provocar problemas con la vista. Entonces vale la pena protegerse y ponerse la vacuna. Es recomendada por personas que tienen más que 50 años de edad. Es una vacuna muerta, entonces es más saludable. Es la nueva vacuna. Era otra vacuna anteriormente que ya no se usa porque la nueva vacuna Shingrix es mejor. Hay 2 dosis, pero es cara. Y las buenas noticias últimamente es que empezando con este año, el Medicare parte D lo está cubriendo. El paciente no va a pagar nada en efectivo, es decir, el parte D lo va a cubrir. Pero hay que tener cuidado, hay que preguntar de su doctor y de su farmacia. De lo que yo entiendo, este plan D se acepta en las farmacias, no en general en las oficinas de doctores. Pero en su farmacia usual, pregúntaselos. Yo creo que vale la pena.
Porque son vacunas que puedan costarle de $200 a $300 y como son 2, pues es bastante el costo de estas vacunas.
Sí, yo tengo muchos pacientes que son interesadas, que quieren ponerse la vacuna, pero no pueden por razones económicas.
Exactamente. Muy bien, doctora, pues hemos cubierto varios temas. We have covered several topics here tonight. And I maybe want you to come back and see if you could give us some final thoughts on, especially on encouraging people to vaccinate if possible, because I know that the news, and they're going to be hearing it over the next few days in the news, that we're trending downwards. We're trending downwards with, with hospitalizations and ER visits, but the infections are actually still up there quite high. So, so if you could just comment on that so that we can close out.
Just to repeat myself is to say things we didn't have things are getting better in that the infections, the people are still sick. There's a lot of COVID out there, but people aren't dying and there's not entire floors of the hospital taken over by people gasping on oxygen, which is good, but that's partly because of medicine, like shots, and so to not get complacent, and especially with these new variants coming that are very contagious, I would encourage people to take advantage of the bivalent booster so that they can protect themselves and protect their loved ones and continue to enjoy some, what's starting to look more and more like normal life.
Okay.
So,
Le pregunto a la doctora y le pido que por favor nos haga una recomendación acerca del COVID para cerrar el día de hoy, porque hemos compartido que va de bajada las hospitalizaciones, las visitas a urgencias para COVID, pero las infecciones aún están altas y aún hay mucho contagio. Entonces, para que ella los anime y les diga por qué es importante vacunarse aún hoy.
la razón es porque lo bueno es que la intensidad de la pandemia es menos en esta región, porque hay menos personas en el cuidado intensivo, menos personas muriendo, mucho menos, gracias a Dios. Pero todavía hay mucha infección. Estas personas están en la casa perdiendo tiempo de trabajo, sufriendo tos, resfrío, calentura, todo eso. También tal vez contactando a personas débiles y provocando enfermedad más recio. Tenemos la oportunidad de protegernos usando la vacuna bivalente para prevenir que no se siguen las infecciones, que si no se enferma a sí mismo y que no se sigue tan fuerte la pandemia. También las más personas que están infectadas, la más oportunidad de tener más variantes. Y porque el virus se puede cambiar si está en una persona creciendo. Otra razón de ponerse la bivalente, de protegerse y de poder tener una vida más normal. Todos tenemos irse a fiestas y a la tienda sin máscara todos queremos tener una vida normal, pero una vida saludable también.
Muy bien. Just a reminder that we will be posting the links and comments for this recording. Y también recordándoles que los enlaces que nos ha compartido la doctora se publicarán en comentarios en esta publicación. We'd also like to maybe put out there tentatively that we will have our next session. It's actually lands during school break week for spring break. So we are probably likely pushing it back to the following week, the following Tuesday, April 4th. So, hold on tight for that, and we will publish that as we get closer to that date. Les queremos compartir que también estos enlaces, como les dije, los vamos a tener publicados aquí, pero también hacerles saber que la próxima sesión normalmente es programada para la última semana de marzo, pero como es la semana de vacaciones de los niños de la escuela, yo creo que la vamos a retrasar con una semana y tenerla el martes que sigue, que sería el 4 de abril. Estén al pendiente, nosotros les notificamos. And we would like to thank everyone. Thank you, Dr. Poulos, for joining us tonight and for covering a variety of topics. Le damos las gracias a la doctora Poulos porque nos acompañó esta noche y nos compartió información sobre varios temas en salud.
And I'd like to thank Natalie for her technical assistance and Martha in the library for hosting me again. And I hope, I always feel like even if one person gets persuaded to get vaccinated, it's worth it.
Yes.
To do these programs.
Sí, es cierto, la doctora da las gracias, ¿verdad? Porque dice que que aún si una persona es la que se vacuna, pues entonces desquitó esta sesión de esta noche. Entonces, gracias. Thank you all. Have a great evening. And I think the next time we'll see you, it'll be close to spring. So it'll be very nice.
That'll be nice.
Right?
Great.
Okay.
Bye
good night,
Thank
everyone. Bye-bye.
Bye-bye.